Trung ương, thạc sĩ bác sĩ chuyên khoa 2 Nguyễn Văn Khoa, phó giám đốc của bệnh viện. Xin trân trọng cảm ơn. Và quan trọng nhất đó là chúng tôi nồng nhiệt chào đón 100 quý bác sĩ tham dự trong ngày hôm nay và 150 bác sĩ và đội ngũ quản lý nha khoa của mình vào ngày mai trong cái chương trình 3D, 3D Round Day của chúng tôi. Một lần nữa xin chào đón sự hiện diện của tất cả quý bác sĩ có mặt trong sáng nay. Và để khai mạc thì xin kính mời bác sĩ thạc sĩ Nguyễn Văn Khoa, phó giám đốc của bệnh viện Răng Mặt Trung ương lên trên sân khấu để phát biểu khai mạc. Xin trân trọng kính mời.
Tôi xin thông tin ở đây để trao đổi các bạn một chút xíu. Lời đầu tiên thì cho phép tôi xin lỗi tất cả quý hội thảo viên, có một sự trục trặc chút xíu về mặt kỹ thuật, cho nên cái hội thảo của chúng ta nó diễn ra để trễ hơn chương trình một chút xíu. Tôi xin phép đầu tiên là tôi xin cảm ơn các giáo sư, đặc biệt là giáo sư Gabriel Chaushu hôm nay đã có mặt ở đây trong cái hội thảo này để chúng ta giúp chúng ta các quý đồng nghiệp của chúng ta có được những kiến thức, những cái kinh nghiệm chia sẻ chúng ta những cái kinh nghiệm về cách xử lý các cái tai biến, các cái biến chứng trong vấn đề lên. Hai là tôi xin cảm ơn tất cả các hội thảo viên, những người đã rất đam mê cái chuyên môn về implant. Hôm nay cũng dành thời gian để có mặt ở đây cùng với ban tổ chức và bệnh viện Răng Mặt Trung ương là cơ quan đồng tổ chức với công ty 3D và MIS cũng như các công ty đối tác của 3D trong ngày hôm nay. Thực sự thì bệnh viện Răng Mặt Trung ương của chúng tôi cũng đã làm việc với 3D rất nhiều lần, và trong cái ý hướng là phát triển về mặt chuyên môn thì bên lãnh đạo của 3D cũng đặt vấn đề với bệnh viện, và chúng tôi hoàn toàn ủng hộ các cái ý kiến cũng như các cái ý muốn của công ty 3D trong việc phát triển về chuyên môn, đặc biệt là một lĩnh vực mà ở một cái góc độ là các cái vấn đề khó khăn mà anh em chúng ta gặp hàng ngày. Cho nên chúng tôi về mặt chuyên môn thì rất là ủng hộ các cái ý kiến này, cũng như là các đóng góp của 3D cho cái cộng đồng các anh em mà đam mê implant và cũng còn nhiều cái trăn trở, những cái vấn đề liên quan đến implant. Cho nên hôm nay chúng ta có buổi hội thảo hôm nay rất là cảm ơn công ty 3D đã có sự hợp tác rất là chặt chẽ với bệnh viện trong nhiều năm qua, và chúng tôi cũng hy vọng rằng trong thời gian tới 3D tiếp tục có những cái chương trình hay, đưa những cái diễn giả rất là nổi tiếng, thật là xuất sắc ở trên thế giới về anh em mình, và chúng ta sẽ có những cái buổi trao đổi cũng như là học hỏi kinh nghiệm của những cái diễn giả nổi tiếng trên thế giới tại Việt Nam này với cái chi phí tối thiểu. Và chúng ta cũng biết rồi, một cái hội thảo ở nước ngoài thì chúng ta tốn nhiều ngàn đô để chúng ta tham dự. Tuy nhiên khi chúng ta tham dự ở Việt Nam thì cái chi phí nó giảm rất nhiều. Chúng tôi rất là mong muốn anh Thắng, anh Hiếu, công ty 3D, những người lãnh đạo của 3D trong suốt 15 năm qua tiếp tục cái công việc này, đưa các diễn giả về Việt Nam để anh em nha sĩ Việt Nam có điều kiện cũng như đỡ mất thời gian hơn, đỡ tốn tiền bạc hơn, thì chúng ta có những cái buổi học hỏi rất là bổ ích như thế này. Và thay mặt cho bệnh viện Răng Mặt Trung ương, chúng tôi xin chúc cho cái buổi hội thảo của chúng ta, 2 ngày hội thảo của chúng ta cũng như các lớp hands-on của chúng ta trong ngày mai thành công và thành công hơn nữa trong tương lai. Xin cảm ơn.
Xin cảm ơn bác sĩ Nguyễn Văn Khoa đã phát biểu khai mạc. Kính thưa quý bác sĩ, đến với sự kiện lần này thì chúng ta có các diễn giả ở trong nước và quốc tế, cũng như là các bác sĩ hỗ trợ cho công việc dịch. Xin kính mời giáo sư Gabriel Chaushu, bác sĩ Chaushu Phần, thạc sĩ bác sĩ Phan Hoàng Hải và bác sĩ Nguyễn Minh Quân lên trên sân khấu để cho ban tổ chức có thể tặng hoa. I kindly invite the speaker to go up on the stage and receive the flower from the organization committee. Xin mời các bác sĩ. Xin kính mời bác sĩ Nguyễn Khoa, giám đốc bệnh viện Răng Mặt Trung ương lên trên đây để giúp tặng hoa cho các diễn giả và các diễn giả. xin dành cho một ngàn pháo tay để chúc mừng những chị trẻ chúng ta hôm nay. Ok, thank you. Xin cảm ơn. Kính thưa quý bác sĩ, trước khi chúng ta bước vào bài trình bày của giáo sư Chaushu, Thắng xin có đôi lời giới thiệu về ông. Giáo sư Chaushu là trưởng khoa phẫu thuật hàm mặt, trưởng khoa trường nha The Maurits and Gabriel, Đại học Tel Aviv, Israel. Ông là trưởng khoa phẫu thuật hàm mặt của bệnh viện Beilinson, Israel. Ông là tác giả của hơn 150 công trình nghiên cứu khoa học được công bố ở trên các tạp chí hàng đầu. Ông nằm trong ban biên tập của các tạp chí chuyên ngành như International Journal of Oral and Maxillofacial Implant, Clinical Implant Dentistry and Relief Research, Journal of Investigate and Clinical Dentistry, Case Report in Dentistry, Smartology Education Research, and Clinical Oral Investigation, cũng như những tạp chí khác. Ông là báo cáo viên thường xuyên của các hội nghị khoa học ở trên toàn cầu. And now, ladies and gentlemen, I would like to invite Dr. Chaushu and take the floor with his presentation. Please welcome. Xin chào đàn pháo tay để chào đón giáo sư Chaushu lên sân khấu để trình bày bài buổi sáng ngày hôm nay. Xin cảm ơn tất cả quý bác sĩ và chúc chúng ta có một ngày thú vị, cùng làm việc với nhau, học hỏi được nhiều điều để giúp cho công việc chúng ta được thành công hơn. Yeah.
Thank you very much. Thank you very much. And it's really a pleasure and honor to be here in front of you in this beautiful city of Ho Chi Minh or Saigon, like it was called before. And first of all, I'd like to thank you all for taking the time to come here. I know it's not easy. Everybody has his own clinic, has his own patients. So to be out of your clinic for 2 or 3 days, it's not a simple issue. So I really want to thank you for that, and I hope I will justify your time coming here. And second, I would like to thank the companies that supported my arriving here, 3D company, and of course Dentsply, Sirona, and MS company, and Datum Dental, especially Shlomi Barazani and Ronit and the representatives of 3D. Thank you very much for supporting this trip. So, it really gives me a special pleasure to be here and to see all this beautiful crowd, and it is even a bigger pleasure to see so many beautiful women here. It's really something new in dentistry. It used to be a male profession. Now the number of women going into this business is higher and higher. At Tel Aviv University, more than 60% of the students are women. So we're very proud of this, we're very happy of this, and I think that this woman touch will help a lot to advance the profession in different directions and different visions. Well, today I will try to show you several things and the way we do it and the way we experience with our successes and our failures. But you must understand that this is not the only way to do it. There are many solutions to many problems. And the fact that we're doing one solution does not mean it is the correct one. There may be also another solution, or different solutions. So, we Israelis are not very polite. We usually say everything that is on our heart straight away. So don't be too polite. If you think you disagree, if you think you have a better solution, if you think you do it in a different way, tell me. Let's speak about it. Maybe I will convince you. Maybe you will convince me. Usually when I give a lecture, I always learn from the audience. It's not only me giving my experience, I also learn from their experience. So I'm sure there are here a lot of people with a lot of experience, so let's share it. Let's speak. Okay? So we have things to say them to me. Don't be afraid. So, the first topic is implant failure. You know, when I teach my students, I ask them, what are the biggest changes through the last 2 decades in implant dentistry? And they tell me digital, and they tell me a lot of things. And yes, those are improvements, those are big changes. But eventually, I tell them there are only 2 big changes in implant dentistry. The first one is implant surface. The transition from machine to rough surface changed everything. And why is that? Because the BIC you will get with a rough surface is more than double the BIC you will get with the machine. So basically, an 8mm rough surface will give you a similar BIC like a 16mm machine. So this is a huge difference that actually allowed us to do implants in many situations that we couldn't do before. And the second biggest dramatic change in implant dentistry is the fact that we eventually admitted that implants fail. Only diamonds are forever. Remember 007, James Bond? Only diamonds are forever. Implants are not forever. Okay? So when a patient asks me, what guarantee do you give to my implant? I say, I give a guarantee up to the door. If it fails when you go to the door, I put another one. If you pass the door, I don't put another one. And he says, how come? A lot of advertisements. Implants one day, implants forever. I say, look, I'm a doctor, I'm not a magician. You want to go to a magician, go to a magician. So really, we need to be careful about what we say. We need to be careful about what we do. Now, what is the biggest problem today? Today we know that the treatments recommended to the patient are much more complex. You can see, as I told you before, man is a very simple machine. Only one button up and down. Women is a more complex machine, you know. And the second thing is the risks. Today, because of the competition, sometimes we're taking too many risks. And many times those risks are unnecessary. And because there is such a complexity, and there's such a need to take those risks, we need somehow to develop this knowledge. We need somehow to develop the way to cope with this complexity, to cope with those risks. But basically, there is no accepted knowledge in implant dentistry aimed at defining the level of treatment complexity and the potential for complications. So sometimes we feel lost. Now, I'm practicing implant dentistry for more than 30 years. I will not tell you my age, I'm too old. But one thing I learned throughout the years is that the most important stage in implant dentistry is the preoperative evaluation. And if you do a correct preoperative evaluation, it will help you in everything. Now, the preoperative evaluation will assist you in evaluating the degree of difficulty of individual cases. It will provide you appropriate planning and treatment. It will help you establish a realistic dialogue with the patients regarding outcome limitations. It will help you speak with them about post-operative morbidity, and it will help you explain to them about complications. So if you have a realistic dialogue with your patients, it can save you from many catastrophes. And you need to do that as a pre-operative evaluation. If you don't have the same expectation as the patient, or the patient doesn't have the same expectation as you have, you'll get into trouble. So let's look at this case. I was a very young head of department at the age of 37, and then the head of the hospital comes to me and says, "Oh, Gabi, this is my cousin. She lost one of her front teeth. I'm going to bring her to you that you can treat her. I'm sure it's nothing for you. It's a very simple treatment, only one tooth. I'm sure it's no problem." So I look at him, it's my, I was just appointed head of the department, he's the head of the hospital, and I look at the case and say, "Are you crazy? This is a simple case, come on." I look at the 3D, I see some amount of bone that is lost, and I look here at the paraxial view, I see that we barely have 2 to 3 millimeters width, and we have a lot of vertical bone loss. So, I was really very worried because, I had to cope with the expectations of the head of the hospital. But I was very lucky because this cousin of the head of the hospital, she was a very intelligent woman. So I could speak to her. We don't always have very intelligent patients, We hope everybody is very intelligent, but unfortunately not always. So I explained to her, "Look, lady, we can do this case. We will succeed in placing an implant, but I cannot guarantee you 100% aesthetic result." And she says, "Why?" I said, "Because we have bone volume loss, periodontal support loss, so the chances are not 100% success. So if you want, we can go ahead with that. If not, we can just do a 2-supported bridge. Why not do a 2-supported bridge?" He said, "I don't want you to touch my other teeth. I'm afraid that I'm going to lose them. So I'm willing to go with you." And this was really the most important thing in the treatment of this patient. And why is that so important? We're going to speak all day long about augmentation, 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 augmentation. And we need to realize the difference between GTR and GDR. Those are 2 different things. If we speak about Melcher, already in 1976, when he spoke about perio, he said that the root surfaces may be populated by 4 different types of cells. Epithelial cells, cells derived from the gingival connective tissue, and cells derived from the bone, and cells derived from the periodontal ligament. So basically, when you're doing regeneration nearby teeth, you can expect either one of the scenario, 1, 2, 3, or 4. If the cells will come from the epithelium, you will get long junctional epithelium. If the cells will come from the connective tissue, you will get connective tissue adhesion. If the cells come from bone, you will get root resorption and ankylosis. And only if the cells come from the periodontal ligament, you will get cementum, which is the most difficult tissue to gain around teeth. So to gain cementum is the only way you can gain vertical height around teeth. And the chances for that are very, 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 very low. If you go back to GPR, it is much more simple. GPR is the mechanical exclusion of undesirable soft tissue from growing into the osseous defect, thereby allowing only osteogenic cell population. So in GPR, the regeneration is only of one tissue, bone. And once you are able to enclose the compartment with bone, it is relatively easy. So if you want to compare GPR to GTR, you need complete coverage. But when you go for GPR, you will have primary soft tissue closure. So it's very easy. Whereas when you go to GTR, you always have an open wound. My first lecture as a student in perio, my professor said to me, you know what is the difference between a perio injury to any other injury in the body? He said, no, professor. He said, it is the only open injury in the body. There is no other place in the body that you will have an open injury. The only place in the body that you will have an open injury is the periodontium. That's why you will never have primary soft tissue closure around teeth. In GPR, due to primary closure, you can maintain sterile conditions. In periodontal situation, it is much more difficult to maintain sterile condition. In GPR, it is relatively easy to stabilize the membrane. In GTR, it is much more difficult to stabilize the membrane. The adaptation of the membrane is easy in GPR. It is much more difficult in GTR. Space macing in GPR is easy, much more difficult in GTR. That's why GPR is highly predictable, whereas GTR, the predictability is very low. So, the first thing that you're going to look when you're going to do augmentation in a patient that is partially edentulous, you need to see the bone level of the adjacent teeth. If you don't pay attention to the bone level of the adjacent teeth, you don't know how far superiorly you can go. In some cases, in order to gain better vertical bone, you need to extract a completely healthy tooth. Otherwise, you will not be able to get your vertical augmentation. So always do this preoperative evaluation. This will save you a lot of trouble. So we started the case. We did initial surgery, open. You can see the defect. You can see the vertical height loss and the cementum loss on the neighboring teeth. We tried to cover that. You're going to see a lot of cancerous allogeneic bone blocks along this presentation because I used them a lot in the past. Today I'm using the O6 bone instead because it's giving me a much better solution, but in the past this is what we used. So we tried to compensate by using a J block. A J block, the reason to use the J block is because you can gain the blood supply from the horizontal part, and you hope that this blood supply will go to the vertical part. So by using the J block, you hope to gain horizontal and vertical bone in the same time. So this is why you use a J block. And because we wanted to gain also cementum, we use in this case enamel matrix derivatives, like you do in any periodontal regeneration. So you can see I worked for this case together with my colleague from the perio department, Professor Chaushu Phần, which is also very well known, published a lot of articles in many issues. So we've been working, two experienced practitioners, one a periodontist and one a maxillofacial surgeon. Remember, he's the head of the hospital. We need to do everything to make him happy. So he's been working with this enamel matrix derivatives, trying to get cementum. We also put some bone near the teeth in order to gain papilla. We are very inspirative. We wanted to try and really do the best for the patient. Covered everything again with enamel matrix derivatives. And why did we do that? Not only because of gaining cementum. We know that enamel matrix derivatives promote healing of surgical wound in the right oral mucosa. This is a study that was done by a master student of Professor Minkowski, and they demonstrated that once you use enamel matrix derivative, it will promote formation of blood vessel and collagen fibers in the connective tissue. So we basically try to do all the best we can in order to promote wound healing. We did primary closure, 1 week follow-up, and we had some dehiscence, as you see here, but it was not very dramatic. When we have a dehiscence, we basically do nothing. We just try to use chlorhexidine gel to keep it clean and sterile, and eventually it will close. If you try to suture, it is the worst thing you can do, because the soft tissue cannot hold the tension of the sutures. So if you try to suture, you'll get a bigger dehiscence and a bigger problem. I know that for a surgeon, it's very difficult to keep his hand like this. But the best solution in this case is to keep your hands in your pockets and not to do anything. So we open it. In this case, initially we didn't use a membrane. Why was that? Because we didn't know what would be the results of using the blow graft and the enamel matrix derivatives, and we're afraid that we'll have a bigger incision line opening. And as you see here, part of the graft is revascularized, but the most occlusal part of the graft is actually dead bone. It did not revascularize. And we also have some resorption over the screws. But this is not dramatic, because we had enough bone gain to enable the placement of an implant. So, if you remember how we started, this is how we ended at the first stage of bone grafting. So, now we place an implant, we do additional bone grafting. Now, we cover it with Ossiplast, and of course, we release the flap in order to gain maximum vertical closure and vertical support. And remember, we're working all the time together, a periodontist and the maxillofacial surgeon, because we want all the points to be addressed. So we opened it at second stage surgery, and really not much success. We didn't gain much more bone. And we reached this stage at second stage surgery. So now my colleagues, Professor Rumkowski said, you know what? I will try to compensate for the lack of bone by doing soft tissue manipulation. We are periodontists, we know to do soft tissue manipulation. Let's do some soft tissue manipulation in order to compensate for lack of bone. So, Professor Rumkowski published about the rotated palatal flap, and by using this kind of flap, he's able to compensate for lack of soft tissue, for lack of keratinized mucosa. Just to show you in a few words, you see in figure 1, lack of keratinized and cover screws. Buccally, you do an incision in the palatal area, then you advance all this flap buccally. Now you have a denuded part of bone. You don't want to leave it like that, because if you leave it like that, you might get more bone resorption. So what you do, you take like a finger flap. The maxillofacial surgeons know it from closure of orantural fistula. It's like a palatal flap, like a finger palatal flap to close the orantural fistula. You take the same finger palatal flap, you advance it buccally, and you leave the raw area more palatinally. So this way you can gain soft tissue, and you can gain keratinous tissue and soft tissue volume over the implants. And you can see here the healing. Another article published by them in PPAD demonstrating the use of this soft tissue in order to correct soft tissue defects. So you can see here that he did a rotated palatal flap, and really we did our best. We did everything we could. And this is how we started, and this is the final result. If she doesn't open her mouth, it looks okay. But if she opens her mouth, it's really an aesthetic catastrophe. Okay? So, this is not a success. This is a failure. Okay? But sometimes, even though you have a failure, because you started with a realistic dialogue, the patient will be happy. And the woman was extremely happy. And the boss called me and said, oh, you did a fine job, but I didn't know where to hide myself. But everybody thought it is perfect. So you see, sometimes, even though we have two experienced operators, even though you do a blood graft, which is more complicated than particles, even though you use any possible material you think of, even if you do late implant placement, you do a second graft, you use again the best surgeon materials like the Ossex Plus. Again, you use enamel matrix to reduce. And again, you also do soft tissue manipulation. Really, there isn't anything in the world that we could have done more. Even then, you might fail. So, modesty never did wrong to anybody. Always be modest and always have a realistic dialogue with your patients. So you see, if we speak about failure, we're speaking about cases that even though you try to do your best, it is not good enough. But at least you can go home and sleep well, because you know that you did the maximum you could. Now, let's continue with this preoperative evaluation. This preoperative evaluation is also will serve you to understand whether the case is within your limits or not in your limits. Everybody has different training. So if it's a simple case and you don't have enough training, you can do it. If it's a complicated case and you don't have enough training, don't do it. Just refer it. So all those things you need to assess in the preoperative evaluation. Another thing that is very important is you need to establish a realistic fee for your work. If you're doing an implant in the anterior aesthetic zone, you cannot charge the same price as you charge for an implant in the posterior mandible. You have to work much harder. So you need to establish a realistic fee for your service. Another important issue is you need to establish a realistic scheduling. I can tell you that 90% of my failures are cases that I was doing at 7 o'clock in the evening. At 6 o'clock, I received a call from my wife with a list of all the things I have to bring back home in the supermarket when I go back. At 6:30, I had this patient that I had to see for 3 months. And at 7 o'clock, I have the most difficult case of the day. Okay? 100% failure, believe me. If you do a difficult case, it has to be the first case of the day. You have to give it enough time. You cannot do a bone augmentation in 10 minutes. Maybe you can do, I cannot. You need enough time. Okay? So, all this goes in the preoperative evaluation. You will see that 90% of your failures come from the preoperative evaluation. Okay? You need to think a lot, do little. Not think little and do a lot to compensate afterwards. You must be aware of the patient's medical status. And your patient needs to have, as I showed before, realistic expectations. If you don't have realistic expectation, then it's a problem. Now let's look at another case. Very similar to the first one, but in this case, a patient with completely unrealistic expectation. A 50-year-old lady, very fancy, very smart, with a lot of money. I'm a very important lady. I do a lot of commerce with China, with other countries. No problem of money. Okay, what do you want? I want you to take out this implant and place a new implant. I said, okay, no problem, lady. But it will go like that. We're going to take out the implant and we're going to wait 4 months. Then we're going to do a bone augmentation and we're going to wait another 4 months. Then we're going to place an implant and we're going to wait another 4 months. Then we're going to do implant exposure and we're going to wait 8 weeks for soft tissue maturation. And then we finish the case. So we start today, finish in about 2 years. She looks at me, are you crazy? I'm a fancy woman. What am I going to do 2 years? They told me you are the best. I see you do not know anything in implant dentistry. I said, no problem, lady. The door 3 meters there, you can go out, no problem. Many other dentists in Israel. I'm not the only one. Maybe I'm the fattest, but I'm not the only one. So she went away. And I said, thank God. And then, after 1 year, she comes back to the clinic. She says, I'm very angry with you. I said, how come? What did I do so far? You did not convince me enough to stay with you. What? What do you mean I did not convince you enough? You just sent me to the door. You had to tell me that you are the best and to convince me that you are the best. I said, lady, the only woman I convince that I'm the best is my wife. All the other women, I don't care. So she comes again and she says, look, I went to this doctor. He promised that he will do everything in one day, and he didn't do anything. So I want you to do the treatment. I said, okay, but you remember the time schedule? Yes, yes, okay. So, this was at the first visit. Now at the second visit, you can see here, of course, more bone is missing because the implant was removed, and it was removed in a very aggressive way. No augmentation was done. So the situation now is even worse. But the big difference is that we're going to do GBR and not GTR because we don't have any perio problem. So this is a completely different issue. Now this is a pre-evaluation. We open, you can see here the bony defect. Again, I've been using this cancerous block allograft. Covered it with particles, and in this case we used a double layer of 6+, because we learned already from the first case that if we don't use a membrane, we will lose bone. So we wanted to have the maximum bony preservation. And the big advantage of those 6+ is that this membrane will last for 6 months because of the cross-linking. And because it will last for 6 months, it will give you support and will prevent resorption. And when you're doing bone augmentation, the most important thing is soft tissue release. Again, soft tissue release. When you think that you released enough, try more. My tutor in implant dentistry was Professor Michael Pele. He's now in Miami, head of the Department of Maxillofacial Department at the Miami University. We're a very good friend, and he was really my tutor. And I spent 1 year in Miami doing the fellowship in reconstructive surgery and implant dentistry. And I remember one case. I was doing the case, and I started to release the soft tissue. And I was really very proud of myself, because really I had a very nice soft tissue release. And then Michael comes, he looks at the case, and he says, when do you start releasing the soft tissue? I said, what? He said, yes, when do you start releasing the soft tissue? And I said, but I already, no, this is not a release. You think you release the soft tissue. Let me show you how to release the soft tissue. Okay? So, there is not too much release. If you want to know how much soft tissue you want to release, you need at least 10 millimeters more than you have for closure. Why? Because you need 5 millimeters to face each other. So if you release the soft tissue, and the soft tissue just contacts the other part, it will open. You need extra 10 millimeters. It sounds a lot? Yes. But if you have extra 10 millimeters, it will not open. If you don't have extra 10 millimeters, it will open. I can promise you. So, if you know how to get extra 10 millimeters, do the augmentation. If you do not know how to get extra 10 millimeters, don't do the augmentation. Or in certain situations, you can use O6 bone or Volumax because those products do not necessarily need primary closure. And this is a big advantage of those products, and I will show you cases. Because these products can help you in those situations. But again, up to a limit. You cannot abuse the material, you cannot abuse the biology. And as you see here, we've got primary closure, and you can see how much vertically we go up with the flap. So, after 4 months, we managed to gain bone very nicely. Most of this augmentation is horizontal augmentation. And this is how we started, and this is where we went. And again, look at the soft tissue. You can clearly see how much bone we have buccally. We're going to speak later about the amount of bone you need buccally in order to gain an aesthetic result. And we open, and look how nicely the O6 membrane ossifies. Look how nicely it ossifies here, and when you remove it, you don't have any bone resorption. Can you make the voice?
Patented Glide Matrix technology mimics the natural collagen cycle in our body. Glide Matrix is what powers O6 products for guided bone and tissue regeneration. Glide Matrix is clinically proven, covered by over 100 scientific publications, with extensive clinical experience worldwide, spanning decades in hundreds of thousands of procedures. Let's take a closer look. First, natural type 1 porcine collagen is extracted. Then molecular triple helix collagen is released and extracted, then purified. Next, during enzymatic treatment, immunogenic telepeptides are eliminated. During fibrillation, thin fibrils bundle together to form collagen fibers. Finally, Glide Matrix utilizes naturally occurring non-toxic sugar as the cross-linking agent. The polymeric collagen is then reconstituted to serve as the core for O6 regenerative solutions. Glide Matrix is fully bioprogrammable for specifically engineering long-lasting biomaterials with enhanced stability and specialized properties needed for O6 products. Meet our solutions for guided bone and tissue regeneration. O6 Plus, O6 Volumax, and O6 Bone, the newest member of our family. Glide Matrix powers O6 Plus, the only ossifying membrane resistant to degradation when exposed, and maintains barrier function for 6 months. O6 Volumax is a unique volumizing, ossifying collagen scaffold. O6 Bone, ossifying collagen sponge, promotes true bone without remnants. O6 regenerative solutions are used in a wide variety of indications, from routine procedures to challenging cases. Everything we do is designed to give nature its best chance. O6 brand by Datum Dental, redefining regeneration.
So, O6 Plus, now we take a bone trephine because we wanted to have histology and histomorphometry afterwards. And we do immediate aesthetic restoration. You can see here that there is no contact on occlusion that enable us to do this immediate aesthetic reconstruction. As you see here, we waited 8 weeks for maturation of the soft tissue. A zirconia abutment, as you see here. And the lady wanted also some laminates and new crowns, so we added laminates and crowns, as you see here. And eventually we finished the case, which looks very nice from my point of view. But do you think she was happy? Of course not. She said, oh, it's a terrible result. I'm going to go to court and I'm going to sue you. I said, okay, go to court and sue us. So, sometimes you do a good result, but a good result is not good enough. So again, everything has to be established in the preoperative evaluation. So, all those cases we gathered and we published this recently in the International Journal of Periodontics and Restorative Dentistry. And as we said before, a failed implant site is prone to reduced alveolar bone volume both horizontally and vertically. And we wanted to assess the outcome of using cancerous bone block allografts covered with osteoclast in regaining bone and in doing the second bone implantation. The inclusion criteria were failed implants, massive bone loss, reconstruction of the alveolar ridge with cancerous and osteoclast, and we took bone biopsy. So we had 16 patients, 24 blocks, 58 implants. At 6 months, we had very nice post-op results. Our mean follow-up was 40 months. And look at the bone gain. We had very nice bone gain. We had a mean bone gain of 5 mm horizontally and 7 mm vertically. And we had a very high success. 1 block failed and 3 implants failed. But again, we had very nice success results. When you look histomorphometrically, we had 40% uniform bone. This is after 4 months. All the biopsies were taken during implant placement after 4 months. 20% residual bone, cancerous block, and 40% marrow and connective tissue. So our conclusion was that the use of cancerous blocks and osteoclasts would allow us to do good reconstructions in cases of failed implants and massive bone loss. Now, in order to avoid failures, or in order to cope with failures, what are the decisions that an operator can make? We can choose the brand, type, dimensions, and number of implants. We can use the most suitable implant and abutment connection, not like this. Yeah, this is not how to choose. And we need to do a good implant position and spacing, and we need to use restorative materials that are appropriate to the tasks. So basically, when you go into a challenging situation, you want to have with you really the best materials in the world. You want to have first number 1 material. You want to have the Messi of the implants, you know? So, actually you have the Messi of the implants. And this is the Messi of the implant. And I want you to be with me, and I want you to concentrate, okay? Because I don't call it the message of the implants only because it's marketing, and this is our sponsor. I want you to see the logic behind every millimeter in this implant. It's really the best implant and the smartest implants you'll need. And let's see every part and what does it mean. And I will show you that you will not find these qualities in any other implant. Now, it is made of titanium alloy, grade 25. This is not something new, it is not something special. The conical connection here is 12 degrees. So this 12 degrees enables you a very good contact, a very good support. You have other implants which are conical, but this 12 degree allows you, on one hand, good support and good fit, on the other hand, easy handling. So, when you place the implant, always bear in mind, because you have 6 grooves, that the groove is buckling to be able to place angled abutments. Now you can see that at the conical connection, you have more than 3 millimeters, giving you good support. You have those implants at almost any size that you need, and they have a gentle conical connection. This conical connection gives you a definite seal and absolute, stable, and easy fastening. And we're going to see in a few minutes what does it mean. Another important feature is platform switching. You can see exactly the dimensions of platform switching for each diameter. Of course, the wider the implant, the more platform switching you will gain. But you have a very nice platform switching that will allow you to have rest marginal bone loss. The micro rings give you better BIC on the most critical part, which is the crestal part. Dual threads. Dual threads will allow you 2 things. One is better BIC. Second, faster insertion of the implant. And you can see that the insertion rate is 1.5 millimeter per revolution, meaning it is not a very aggressive implant. And it is a big advantage because very aggressive implants will give you very aggressive bone resorption. Whereas implants that can gain stability in a different way, which is not aggressive, will allow you, on one hand, very good primary stability, but will avoid the bone resorption immediately afterwards. So we're going to see bone stability with the C1 implants. Self-plastic acid etching, you know this is not something special. You have the spiral channels and dome apex, which enable you bone condensation and safety when you reach vital structure like the Schneiderian membrane. But the most important issue and the real secret of the C1 implants is the DSM. And DSM stands for Dual Stability Mechanism. You will not find such a solution in any other implant that you will have. And why is it so important, this dual stability mechanism? The first part of the concept is to have a single-use drill, final drill. And why is that so important? Because if you have a single-use final drill, your final osteotomy will be perfect. And it will be like a circle. If you do not use single-use drills, then they are not sharp anymore. And instead of having a circular osteotomy, you will have an oval osteotomy, depending on how much Parkinson you have on your hand. And then, if you want to have a perfect fit between the implant and the osteotomy, you will not achieve it. You can achieve such a perfect fit only if you use a single-use final drill. And yes, if you have several implants, open the final drill for every implant, because you will have better fit. So this is the first idea, because in all other implants, if it is not one use, it will never fit. The osteotomy, when you use your drills for the 200th time, is not the same like you use your drill for the first time. And be honest with yourself. How many times did you switch your drills? The manufacturer recommends every 20 implants. Who is switching his drills every 20 implants? Tell me, who? Okay, the same in Israel. So, if you do not switch your drills, the only way you can have a perfect osteotomy is by having a single-use final drill. Now, once you have this final drill, you will have a perfect fit in the cresta 2/3 of the implant. And because the macro will give you bone compression, you will have very high primary stability regardless of the length of the implant. I will show you some studies that demonstrate that you will have the same primary stability with an 8mm implant as you will have with a 13mm implant. Why? Because the cresta 2/3 will give you this primary stability. Now, this is the secret. The apical part is completely not fitting. The apical part is just open. You will hardly have any BIC in the apical part. And why is that? Because when you look at wound healing, at the beginning of the wound healing, the macrophage, the osteoclasts, have to come in and clean the area. Only if the area is clean, you can allow new bone formation inside. But in this case, they don't need to clean it because it's empty. So bone apposition can start at day 1. So you will have secondary osseointegration, or what we call secondary implant stability, much faster. So in the first weeks, we will have primary stability from the cresta 2/3, and from the 5th and 6th week, we will have secondary stability from the apical third. There is no implant in the world using this mechanism. And this will allow you one-stage surgery, immediate loading, and this is not prone to bone resorption like the aggressive implants. If you have aggressive implants with aggressive strength, cutting the bone, they're putting a lot of pressure on the bone. You're going to have pressure resorption. you're going to have a lot of MBL in the first year. Whereas, when you're doing 1.5 millimeter revolution, but you are based on close approximation, then you'll have an amazing primary stability without marginal bone loss. Think about it. No other system in the world will give you such a solution. So as I told you, the DSM gives you primary stability initially and very fast secondary stability. This is a study that was done by Paulo Coelho and was published in the International Journal of Biomaterials, and he demonstrated and described to see two different drilling protocols, which is another advantage of C1. Because you have a final drill, you can do pilot and final, or you can go slow to protocol. But if you're terribly in a hurry, you can do pilot and final. And Coelho already compared those two protocols, as you see here, 10 years ago. So they placed implants in two protocols. One is on the range on the protocol, and the second is pilot and final. And they check two things. One is BIC, which is the primary stability, and the second is BAFO. BAFO is bone area frequency occupation, meaning how much, what percentage of the interthread space is occupied by bone. And the BAFO today is the way we try to see, we try to test secondary osseointegration. BIC is a test for primary osseointegration or primary stability, and BAFO is a test for secondary stability, either histologically or under micro-CT, depending on the study. So as you see here, you have initially 20% BIC, which gives you a good stability, and the primary stability reaches its top after 3 weeks. You have 50% BIC in 3 weeks, meaning this is a very fast gaining of stability. And the BAFO, again, the secondary osseointegration, you will also have 40% in 3 weeks. So when you remember the graphs, there is always a graph on immediate loading that you have loss of stability between the 3rd and the 6th week. And you gain stability again after 8 weeks. But with this design, you compensate for this leg. So you don't have problems either for one-stage surgery or for immediate loading. And you really don't have any other implant in the world with this dual stability mechanism. And this is how it works. Number 1 is the C1 implant. Number 2 is all existing bone. Number 3 is the existing drilling line. Number 4, this is the compartment that we're going to check on the BAFO. This is the area that we're going to check on the BAFO. And this is how it works. First week, osteogenic tissue, close proximity, but it is empty. Week number 2, beginning more contact, bone and implant surface. Week 3, moving bone replacing again. And after 4 to 5 weeks, we have moving bone filling the compartment and calcification. So remember this BAFO, remember the rate of new bone formation in the BAFO. This is eventually the most important thing for the long-term success of the implant. So again, final drill one side, DSM macro on the other side. Those are the combinations that are unique and allow you the refinement of the C1. Let's go through several studies. Again, from our university, combination of the perio and cross departments, they wanted to examine the individual and combined effect of bone type, implant length, implant design on primary implant stability, and the outcome parameter was insertion torque, ISQ, which are measures of resonance frequency analysis using two devices, Ostel and the Penguin. And as you see here, two artificial bone material, one is dense, the other is soft, two implants, one is internal hex 7, second is conical connection C1, two lengths of implants, 8 millimeter and 13 millimeter. So if you do the mathematics, 2 by 2 by 2 is 8. So they had groups, 12 implants in each group, 96 implants. And those are the results. There are more graphs on the study, but I decided to spare them from you, just to give you this study. You can see here that the stability is significantly increased by bone quality, implant length, and implant design. But if you look at implant length and you compare the conical connection, the 8 and the 13, you don't see much difference. Meaning that with the conical connection with the DSM, you'll have almost the same stability with 8 and with 13 millimeters, which you will not find with the 7, with the internal hex, in which the primary stability on 8 millimeters is much lower compared to the 13 millimeters. This is why I'm telling you it is the importance of the crystal part. Okay, so dense bone will influence any implant, but length, because of the design, will not affect the C1. Because what is important is not the length, it's important the crystal part. So the C1 will compensate for the soft bone and the short implants in primary stability. Okay. So another study trying to check the same things, and it means trying to see the stability after termination, and this is relevant in immediate implant placement and removal of failed implants. So again, 48 implants, 1/10 artificial bone material, 2 implants, internal hex 7, C1, 2 lengths, and the groups, 12 implants in each group. So again, you see that 2 to 2.5 millimeter BRC will give you enough stability. So the conclusion was that immediate implant placement is predictable as long as at least 2 to 2.5 millimeter of bone are engaged, and the biological stability will not compromise the mechanical stability. So the conical connection will give you a good implant stability. What about bone loss and other studies on humans? You can see again that insertion torque without implants is high, and you can see that marginal bone loss is very little. So again, it maintains marginal bone loss and it gives you a lot of stability, as you see here. Same in the anterior mandible, as you see here. And 5-year follow-up demonstrating the same, less marginal bone loss and a lot of stability. So those are the implant connection types. And of course, the internal connection has advantages, as you see here, over the external hex. And the main reason is that you have 2.2 millimeter engagement versus 0.6 millimeter engagement in the external hex. But the conical connection will give you an even better result because of the 3.2 height, which will give you better adjustment of the abutment to the implant. And again, we spoke about this. So the conical connection will increase the contact between the implant and the abutment. It will improve the records of the implant. So it will improve the restoration stability due to minimum abutment micro-movements and reduced incidence of screw loosening. Platform switching concept, we saw it before. The idea is to medialize the implant abutment junction and to reduce crestal bone loss. As you see here, the pressure is moved to the center of the implant from the periphery of the implant. And again, studies that measure bone loss compared between 4 connection disconnections in internal hex implant versus conical connection. And you can see that the conical connection will give you 4 times less bone resorption compared to the internal hex implant. So, again, preservation of marginal bone loss. Another study that checked with the C1, the marginal bone loss. And again, you can see here that this is the design, but what is important is to go to the amount of bone loss. You can see here that the amount of bone loss was really very minimal, 0.4 marginal bone loss. And if you look after 5 years, the same. Very stable result. Again, penetration of microorganisms is very low in this connection, and the micro leakage is very low, and you will get also greater resistance to the formation and fracture. So, if we try to summarize, the conical connection will give you a better abutment fit, a better stability, and a better seal performance. Okay, so let's stop here. Let's take a break, and we'll come back after the break and continue. Okay, thank you. If you have any question up to now, you can do that. Any question?
Dạ, chúng ta có câu hỏi nào không ạ? Nếu chưa có câu hỏi nào thì chúng ta có 30 phút giải lao